First of all, I just want to introduce myself. I'm Janet Brooks, and my subject matter expertise right now is SSI, and I probably feel like I know every one of you in the room from different questions that I've answered. My mailbox now, people just say, send it to Janet, so I feel like I know all of you quite well at this point. I know where you are and how you feel. I had over 20 years experience in the trenches as an infection preventionist at large and small hospitals, so I know the trials and tribulations with, especially as we change our definitions. I want to welcome everybody here in the room and those of you that are listening via web streaming today, all of those probably thousands that are on there right now. I haven't heard a number yet from Courtney of how many are logging in, but I'm sure there's a lot of people listening. Let's go ahead and get started. So our objectives today is to look at our methodology for collecting our data and identify, we're going to focus on our SSI changes for 2014. I do go over filling in denominator data, that's your procedures, and your numerator data, which is your surgical site infections. So especially for the newer IPs, this can be helpful for everybody. And then how to apply these definitions to some case studies. And I've sort of thrown case studies throughout the whole presentation this year rather than having a giant chunk at the end. I'm trying to present a piece of information and then see how you can apply that. So I know that Kathy Britson asked early on, but I'm just curious again, how many of you, is it really maybe less than a year that you've been, as a younger IP or new as an infection preventionist, are less than a year working with SSIs? Okay, good. I just want to kind of get a feel for that, because I do go over the basics and then some advanced issues. Well, this is my, the go-to spot. We're on the NHSN website, and this is your surgical site infection section. And over here on the right, you can quick link rather than dragging down to the bottom of the page, get to your trainings, your protocols, your data collection forms, whole section on CMS reporting materials. The bottom are supporting materials, and I'm going to be going over that in a minute. You can quick link to your analysis resources, and I have to thank Maggie for her presentation. I mean, perfect timing in terms of really hitting a lot of the SSI questions that I get as well that she gets around what's going on with risk adjustment and what we're collecting right now, some of this new data. And then we have our frequently asked questions. And I think it was mentioned early on, I'm not sure by whom, but we've just finished updating all our FAQs to reflect the new definitions and the new protocols, and there were quite a bit of changes for SSI in 14. And I think probably within the next week, the FAQs that I get, for SSI protocol will be up there. And we've actually moved this time up into this protocol section here where you grab your actual protocol. So you're going to find your FAQs up there. Before you had to scroll all the way down to the bottom, and we weren't sure it was jumping out enough for everybody. So this is the data collection forms, and again, I'm highlighting things that I get asked questions about. What I want to show you is for every data collection form, these are all the up-to-date forms. This is from the SSI section of the website. There is a table of instructions that goes piece by piece for every element you're supposed to be entering on a form. There is a table of instruction that tells you what that piece of information wants. So it's got some good details in it. Those details are often found in the protocol, but it's just good to know there are IPs that don't realize we have a table of instruction for every single form. So here's your actual numerator SSI form, and here's your denominator form, and here's your table of instructions. Now, for CMS supporting materials, I don't personally have to go to that a lot, but I want to let you know that these are the ones that are all geared specifically for SSI information. And the one that I like is this one right here, because I feel like, wow, am I sure I know when they did their last update? Am I sure I know what's coming in the future and what we're supposed to be reporting? And as you can look at this was just updated in December of 2013. So this has all your most up-to-date reporting of requirements. And this is just not SSI. It's that really nice page that they put out that has all your deadlines, when it started, when your due dates are for reporting as well. So that's the one that I find helpful, and I always keep track of the date to make sure I have the most recent one. I'm not putting in a lot of details about CMS reporting because we've been doing it for a while with colos and HIPs, but for the IQRP program, it is still colos and HIPs. Nothing was added in 2014, but we do now have these new PPS exempt cancer hospitals. It's a handful of them. I think it might be more. Last time I heard 11, 13. And they did start in January of 14 reporting colo and HIPs as well. This is the section. If you could see how many times I hit this in a day, it would probably be shocking. This is the supporting materials section down towards the bottom of the SSI section of the NHSN website. So what I use constantly, let's see if I have my little arrows in here. No, I didn't. Yes. This is basically what those of us that have been around a while, and you can tell I've been around a while, called the famous Chapter 17, all of your HAI definitions, okay? We know that. Even though it's called the surveillance definitions for different types, even though it's not, it is a chapter if you printed it out hard copy. I look at that constantly, and because of SSI organ spaces, you have to get really, really familiar with this chapter. And you'll know why, in case this has eluded you as we get into talking about organ space infections. My other favorite is, whoops, go back, is this ICD-9 CM procedure code mapping to NHSN operative procedure categories. Again, I get daily emails from the users, and I love you all. I'm not trying to sound negative at all. Don't take this wrong. But I get emails where they'll send me, say, my patient had blumpty-blump procedure done. Is this an NHSN operative procedure? Is this an OTH other procedure for you poor folks in Pennsylvania? And you know who you are. You know that OTH other category. And I basically have to turn it back around because I never want to give an answer if I'm worried it's not the correct one. And I say because a lot of our procedure codes are based on ICD-9 codes, I'm saying, will you do me a favor and send me back the ICD-9 code for that case? And then I also tell them, but remember, we have this amazing resource where we have mapped all of the ICD-9 codes that could possibly procedure or operative codes into this guide, and here's what it looks like. Now, I just am curious, and how many of you use this? No judgment. Okay. Well, I'm glad I'm pointing it out. Because what you'll see here, and I'll try to highlight it, it comes out, and you can see there's white columns and gray columns. So look over here. I'm going to put this one right here is a 4571, and it tells you. So if all you had was this list that said this was a 4571, I'm like, was that a small bowel? Is that a colo? What does that fit into? It tells you that is in our NHSN colo category. Then you go over here, and you see, oh, I had a 4281. Is that an NHSN operative procedure? And that's a big old no. It's nothing. It is not. You cannot report an SSI to something that was a 4281. And then you go over here and you see a 45.8. And that means it's an invalid code. And if you look in an ICD-9, how many of you guys, I'm asking too many questions, I'll check. How many of you guys have ICD-9 CM code books in your office? Well, we're going to be talking about ICD-10s in a little bit. I highly recommend you put that into your budget. As an IP, and this has nothing to do with what I'm doing now, I couldn't live without my ICD-9 code book to be able to look up and see what is this code, what is this procedure. I mean, it's used daily. So I highly recommend you have that because otherwise you have no ability to look that up on your own. So anyways, if you look up this code 45.8, that is showing it's an invalid code, and when I look that up in my ICD-9 code, it usually means it's one they retired, just not used anymore. So you shouldn't even be finding it. And then, I'm sorry, invalid means, sorry, I've got, the NU is no longer in use. It was an ICD-9 valid operative procedure code, and it's out of use. And this 45.8 is just an invalid code. It would not be any kind of NHSN operative procedure. So that's really, really helpful. And it's all separated out by pages in an Excel document for you all to use as a resource. We also have at the top the training section of the website, and right now there isn't as much on it, and we're going to be updating the lectoras for new IPs, or those of you who haven't done it, to train to the new definitions, and that's actively being worked on now. And then once this webinar is ready, it takes a few weeks, but you'll then be able to find this webinar on the training website as well. Now, your monthly reporting plan is really the roadmap of what data you are sending to NHSN every month, your in-plan procedures that you're following. So for most of you, if you're in an inpatient acute care setting, you're all going to have your colos and your HISTs in there. And then some of you are in states that have very specific other procedures they want you to follow. It might be a handful more, and those will be in your monthly surveillance reporting plan. And then those of you, I'm sorry, in California, how many Californians do we have here? Oh, quite a few. Hi, I moved here from Napa, California, so I feel your pain. Have a very large selection, as well as Pennsylvania. You know, almost every operative procedure in Pennsylvania, and in California with 29 or something, a lot. So they've got a lot in their plan. But the plan, by something being in plan and checked off, that drives and activates all the business rules that live behind an application. So that's what makes it a active in-plan surveillance. And you must have one, you know, it's a month to month. So you have to have colos in every month that you're following those. So this is what your monthly reporting plan, if you had a look at this would be ICU West. And it's telling you can tell that they're following CLABSIs, CAUDIs, and they're just following for inpatient hysterectomies. Now, active surveillance, you know, you've got your procedures being done, but how are you going to find the surgical site infection? So you have to have a surveillance method that's very active and ongoing. So you want to first of all determine which patients need to be monitored. So you need to know who's having, I'm going to focus on colo-HIST because we're all kind of, most of us in the same boat for those two. Which patients are having those procedures every month, and that's important. And there's lots of methods, and these are all pulled out from our beginning of our SSI protocol where we touch on post-discharge surveillance. You can review your admission logs. Those are very important, and your readmission logs. Some people actually can have a code in the logs they run that say this is a readmit of a person who was here in the last 30 days. So that can be a flag for you to let me check this patient and see if they had a procedure. Everybody has different reporting systems that have flags that give them a warning. This may be a patient that is suspicious. You're going to look at the last facility I was in, my admission logs always had their diagnosis. So I mean, if I saw the word like abscess, if I saw the word any kind of infection, I was going to look up that patient just to make sure if they'd had a procedure the month before, did I need to follow that to look for a surgical site infection? Your ED logs are really helpful if you can get that, even if the patient isn't readmitted to your facility. If you can get your ED logs with their diagnosis or some sort of summaries, you can maybe find some of your superficial SSIs where they come in and are treated but then are not readmitted to your facility. Also, you can be reviewing, obviously, all your lab reports for any sort of wound cultures that are being sent. And then you can, other diagnostic tests that you find helpful. And reviewing nurses' notes and physicians' notes on the patients. And then also, what can be good if you have, and I know it can be really difficult, but if you have certain targeted high-risk surgical wards, you can try to get involved on maybe the weekly multidisciplinary rounds so you can in actual real time be hearing about which patients are struggling with wound healing or might be catching early some possible surgical site infections. That being said, at this point, we don't have, because we do get asked this, we do not have an actual set mandatory validated method that we say how you are doing your surveillance or your post-discharge surveillance. That is still fairly, it's customized and it's done, especially the post-discharge, differently in different facilities, and we're going to be talking about that. But it is, again, something that you want to be doing and have a part of your surveillance. There was a misconception in the beginning that CMS would never get any SSIs that are found by post-discharge surveillance, and that's not true. That's the AR model, but the 30-day surveillance where they use the age and the ASA code, they're finding the ones no matter how they're found, whether it's admission, readmission to your facility, post-discharge. So you want to develop some sort of tools and to have a consistent way that you feel like you're capturing your post-discharge surveillance. Now, if you find a patient who's found via post-discharge, they come into the ER, and then that's how they maybe first culture the wound is in the ER, but then they readmit the patient, that would be a readmit to your facility. You kind of go to the deepest level, the most complicated that it occurred, like this became bad enough this patient was readmitted for care of this surgical site infection. And also, again, you can get a connection to reviewing all of your post-op clinic records. And there are also, the ultimate, and there are facilities that have the person power to do this, is if you think about it, especially if you're not a hospital that's doing every single one, it could be difficult. But if you're only doing colos and HIS, you really have to think about the fact these are both 30-day procedures. You don't have to go out 90 days, and have some sort of method that you can review that chart, fully review each chart at 30 days. So this is just a little glance at on the left, you'll see this is the denominator for collection form that's used for every procedure. Now remember, when you sign up to do colos and HIS, you're saying I'm doing every colo and HIS, every procedure in that meets that criteria. And then on the right is your actual infection, your SSI surveillance form. So we're going to go over some key terms. And this is a new slide, this next one. It's not in your packet. This was my little bit of armor that I put on. My friends were joking, saying, you should come on with a bulletproof vest and say, don't kill the messenger. But I know that we have thrown a lot of changes for SSI surveillance at you all in 2013 and in 2014. There's only 2 more coming in 15, which you have to wait to the very end of the presentation to get that. But then we're done. then it's level. Oh, don't quote me on that. But anyway, these changes that have occurred in 2013 and 2014, definition of primary closure, and all the things that we've done this year, did not happen in a little group of people at NHSN saying, let's change up our definitions. There was a year and a half, HICPAC guidelines, HICPAC working groups. There was a year and a half HICPAC SSI working group that was very multidisciplinary: surgeons, IPs, AORN representatives, CDC, NHSN, infection preventionists. And it went on for over a year and a half to really look at trying to harmonize, and you're hearing that word a lot, but to try to harmonize our definitions with the definitions that are really being out there and applied by other surgical professional organizations, like the Society of Thoracic Surgeons and the definitions they use for their complex cardiac cases, like the Society of Orthopedic Surgeons and how do they really look at joint infections, like the Musculoskeletal Infection Society, where we got our new PJI definitions. These are the people that asked for this. This came at a surgeon level of, can we harmonize so that when we look at NHSN data, we really feel like this makes more sense and is more valid. And historically, when you looked at NHSN data in the past, before these changes, and compared it to any of these other surgical societies, we were reporting much lower numbers than they were. So that's why some of why all of the changes came about, were driven by a really, really well thought group of very sharp people that were trying to get this harmonization. So present on admission. This was gone over a lot last year because we have a new present on admission definition, and Kathy reviewed it again today. POA does not apply to HAIs. If you look at the POA definitions, like it has to occur in the first 2 days, it has to do this and that. It doesn't work with SSIs because they're procedure-based. Everything's procedure-based. Think of Maggie saying, you got to be driven by the date of the procedure, and they all have these long 30-day surveillance periods. So the whole POA definition just doesn't even work for surgical site infections. And it says that in black and white now. I mean, it's kind of what we knew was true, but we didn't have it in writing. And then when we had the POA definition, we realized it doesn't apply to like lab ID, to VAE, and it doesn't apply to surgical site infections. They're procedure-based. So once the procedure starts, the clock sort of starts ticking again, is the way I like to think of it. And the HAI definition doesn't work because that's the one that bounces off of the POA and says, oh, if everything happens on day 3, it's an HAI after admission. Well, again, these are procedure-based with long surveillance periods. And the HAI definition is what introduces the whole gap day rule. And we don't apply this tight little gap day to a person who has a 30-day surveillance period. Things can brew and they can start as superficial and move to deep. So we don't have that gap day rule which shows up in HAIs. And that's why we, again, very clearly, if you go into chapter 2, our HAI chapter, you'll see it says, this doesn't apply to surgical site infections. So this was a big change this year. Last year, the big change was the definition of a primary closure. If you think about before 2013, man, that incision had to be just closed up tight as could be and not a wick or a drain coming out. And then we had a new definition, which was very much based on the American College of Surgeons definitions. It's very, very tightly based on NSQIP's definition of operative procedures, primary procedure, versus an open procedure. But what we did in 2014 is, it's all those procedures in Table 1, which we're familiar with. It tells you what they are, or on all the OTH categories for Pennsylvania, and it takes place in an OR where at least one incision is made into a skin or mucous membrane, and also that's your laparoscopic procedures, or an incision left open during a prior procedure. This is to cover for now that you remove the incision method from your definition. It means you may have a patient who goes to the OR and they leave the incision open and then they return 2 days later to close it. Well, that still is a procedure. So, but they're going through, cutting through the fascia or something to start that procedure. So you still want to include them. And then it takes place, this is the same as it has been for the last couple of years, in an operating room, which is defined as a patient care area that meets the FGI or the AIA criteria. And that's the same. That did not change from last year. So again, just to be clear, as of 2014, the incisional closure is no longer a part of a definition of an NHSN operative procedure. So all otherwise eligible, meaning an incision was made and it took place in an OR, will be entered into your denominator data. And if you think about that, it's the same as thinking of, here's my denominator, and you base your surveillance and your writing up of surgical site infections on your denominator. So if it's in your denominator, and they haven't developed an infection in that surveillance period, you will attribute it. We'll get into that more. So these are some of the FAQs that I went ahead and just put them in right at the get-go. So why are both primary closures as well as non-primary closures now being collected as part of the denominator data that's being sent to NHSN for surgical site procedures that are followed in our facility's surveillance plan? Well, both non-primary closures are common now, and the previous definition did not have any representation of this surgical practice. Therefore, it's important to collect data on these procedures and the related infections to really gain a comprehensive picture of the surgical risk factors that are in order to guide prevention needs. So now you're going to have an ability. Now, what Maggie said was really important. Right now, none of these open procedures, the other than primaries they call it, if you look at the checkbox, are going to be impacting your SIRS that you run. They're not being sent to CMS. We don't have any baseline data to look at these. They're there for you to look at, and it can be very helpful for surgeons to be able to see, especially those that do colos and where, not a majority by name, but some are left open, that you'll be able to actually give them information. Okay, here's how many SSIs you had that met this criteria, but you had this many based on this procedure. You have that internally now, but we're not sharing that data with CMS, and it's not affecting your SIR at this point because we're not going to re-baseline. We haven't re-baselined. So everything, as Maggie said, is based on 2006 through 2008 data. Our primary closure definition did not change from last year, same. And you'll remember last year in the manual, we actually gave you, because sometimes you don't know what something is unless you know what it isn't. So we also last year in the NA, and this is just cut and pasted from your manual, we also gave you the non-primary closure definition of incision. And that is right here. Wordy, just because it's a placeholder to remind you, this is your definition from the SSI protocol, okay, for a non-primary closure. It was also in there last year, didn't change at all. We just weren't applying it. So non-primary closure basically means your open procedures. So when you, and we'll get to that in terms of when you fill this in. So if a patient, this is my next most frequently asked question lately, if a patient underwent an NHSN operative procedure with a non-primary closure, so it was left completely open, and subsequently this patient develops a surgical site infection from that operative procedure, must we include this in the SSI in the numerator? And yes, that procedure is in your denominator data. And if the patient develops an SSI that meets criteria within the surveillance period, which is, it will be entered into your I said denominator again, numerator, correction, that should say numerator data, and it will be linked to that procedure that is already sitting there in your denominator data marked as an open procedure. Every procedure when it goes over is going to have a field that says, was this a primary closure or an other than primary? So it is linked to a known open procedure. And this was just a reminder note that the SIRs are not going to be impacted by this collection. We're just getting this baseline data, and then we'll be able to actually look at it and see if it matters. Does it matter? Is there a huge difference between the procedures that are left open and closed? But we won't know that till we get that at least years, two's data from you. All right, mea culpa, a lot of changes. So this has been corrected. If you go back to your facilities and print out key terms and tables of instructions for your denominator, what happened, the SSI protocol itself has the correct non-primary closure definition, but that same definition also lived in key terms, and it lived in the little table of instructions to fill out your denominator form. And we did not remember that there was this little sentence in here about, oh, if it's a non-primary closure, it is not an SSI. So that is incorrect. That is not true. That's 2013's statement. It's been corrected. But if you, by any chance, how many of you work off of a hard copy of a manual versus really going to the site? Probably, yeah, at least half. So if you printed off a hard copy of your table of instructions and your key terms, just go and print those off again so that you have the correct non-primary closure definition. The one most people use the protocol is correct, but I just want to point this out. Now this is a list, and actually it's like I can tell you this is sort of, I have to thank our users. I tell you that sometimes you all show us things or have put together little things that are very helpful and that we like to share. This was a list that someone put together. I tweaked it with the IP a little bit, but she put this together for a training for her OR staff of trying to think of all the examples she could of what would be a non-primary closure, what it may include, what it may be described as, and then what a primary closure may include. And so I thought this was just a really helpful listing of things. And I highlighted the one, and it's very unusual, but you'll see on the left side here, I highlighted this. It doesn't happen very often, but we get enough. I've gotten a couple questions, so we decided we want to make sure we are clear on this, and it also is stated in the protocol. There are some cases where they actually do the procedure. They know they're going to go right back in a day or two. So if you look at the patient from the outside, it looks like they closed up the patient. But actually, in fact, it's just a very temporary closure at the skin. The fascia is completely open. The muscle is open because they're going to just kind of unzip that patient in a day or two and finish the procedure. So in fact, because when you read the definition, it says they must be closed at all tissue levels. And people sometimes wonder, what does that mean, all tissue levels? And this would encompass where, yes, the skin looks closed, but in fact, the fascia and muscle layers are open. And they really do this when they're going to take them usually back to surgery in a pretty immediate manner. But I just wanted to, show you that. Let me see if there's anything else different. Of course, when I've got some slides that'll show you some more examples that may be helpful. I may not like them, but they may be helpful. So, my son is a graphic designer, so I have to thank him for doing this for me. Oh, I know. So, because it's hard for us to grab things from the internet. Sometimes we're not supposed to get from there. And so I said to him, I want one nice and tight, one that has some little closures, one that's wide open. Then he calls me up. He goes, Mom, would you like staples or sutures? So I said, I think I'll go with staples. I think they're stronger. So, of course, this is a primary closure. This is now a primary closure. Now, you probably have packing in here and everything, this, and you might even have a little wound vac placed in here, but this would be open, or you have a wound vac here and a wound vac here, but they've closed this. And this is a other than primary. This is an open. And this, again, could be completely filled with, let me go in here. He did not draw these. I said, no, can you do a wound vac? He's like, oh, forget that. So these are representative of, you can see this was never closed at any skin edges and is just completely packed. That's going to be, because some folks have asked, well, if they packed the whole thing or if they put a wound vac in, does that mean it's now like what you consider closed? Because look at, and I said, no. They never brought any of these skin edges together and they've put that whole wound vac in there. So both of these would be considered fully open, not closed at the level. So when you go into now, this is cut from your actual application when you enter, okay? So when you get here to wound closure technique, it's a drop down and it's going to say primary. And then it doesn't say open, I'm just warning you. Then it says other than primary. So that's your selection right there. Okay? So in the past, what procedures were you sending to us? Only procedures. Until this year, the only thing that should have been going into your denominator data was your primarily closed incisions. That is what, when you sent us your colos, you sent us your hysts, we were taking that all of those were closed primarily. Now, we put out a guidance in a newsletter, and if you guys didn't, look back there in November, after we sent in the NHSN newsletter a summary of what was coming. We've been telling you this for every APIC we told you what was coming, but we told you what was coming, and there was and we'll call it an uproar. There was an outcry, an outcry. They're like, yikes, there's no way that we can have something in place to capture wound culture and be ready for this in 2014. What can we do? Help. So we put our heads together. We really do care. We try to listen, and we said, what can we do? What's a workaround? So we went to our actual people up there with the brains that build these applications. Well, we have rules around when fields have to get entered, and fields get entered way ahead to prepare for what's coming. And this field had been built into the application. We couldn't remove the field of incisional closure. We couldn't remove the diabetes field. They were built into the 2014 application because I've been getting emails that said that newsletter said this isn't coming until 2015. And we said, no, we said in 2015, you really have to have the answer right. And we're giving you the workaround for 2014. And what it said up here in the intro paragraph of this, it said, all SSI fields are built into the NHSN application for release. That was us, and maybe we should have wordsmithed it to let you know. I mean, we couldn't take these fields out. So the workaround that we said was report these denominators the same way you were determining in 13, because in 13 what you sent us was only supposed to be your closed procedures. So how were you determining what your primary closures were in 2013? So I'll give you three sort of examples. A facility I work pretty closely with, because I used to work there for a long time, big university. Well, as soon as this definition changed of what was a primary closure and it was much more open, they built a field into their OR record. They educated the OR, the whole team, and actually, because they didn't know, how are we going to know what's open and closed to send to NHSN? So they, way long time ago, had built in a field that said, in the OR record, that said this is an incision that has a primary closure. So, and they educated them. When the definition changed, they said, okay, new definition of primary closure, and they educated the staff. I've also spoken to hospitals that said, we can't open up every record. We don't have the person power to do that. So we have started looking at the ones we have a flag of, like, we look at every class 3 and 4. I mean, wound class 3 and 4, because they're the ones that were probably left open. And we try to pull out the ones that are left open that way. And then honestly, there were other people that said, well, here's what we do. We send all our colos over. We send all our HISs over to you. And then if during the surveillance period, we find an SSI, and we were like, oh, wait, they didn't close this one. We pull that out then, and we don't attribute that SSI. Was that meeting the definition? Not really, but it was the method they were using, because you had to have something in place to decide what you were sending us in 2013. So that's what we mean by the workaround. What were you doing in 13? And use that same method to fill in those two fields. So if in fact in 2013, we don't think there were a lot of people doing this, but if you were sending all your colos and only pulling them out, the denominator, when you found an SSI attributed one, and not sending us the SSI and not sending us that procedure, what you would be doing in 2014, if you're doing that same thing, that's all you can do. You're not going to pull that denominator out when you find that open procedure. You're going to pull that record out and change that record, because you've now discovered that's a record where that was an open procedure. Okay? So what we'd like you doing in 2014, the fields are there, is working on a method that you will be able to more easily capture the closure method for your operative procedures. Because people have been there surprised. I'm like, I tried to send my January procedures, and they're saying they're incomplete because I don't have incisional closure method on there, okay? So, all right, let's do a case. Get your little clickers ready. So a patient is admitted with a ruptured diverticulum, and a colo procedure is performed in the inpatient OR. The case is entered as a wound class 3. They obtained a specimen in the OR which returns positive for E. coli. The surgeon staples closed the incision at 4 locations with packing placed in between. Is this procedure primarily closed for 2014? Let's get your voting started. Oh, you guys are fast on this. I'm going to give you 10 more seconds. You all get this right after that lovely graphic of my son's. Yes, 90% of you said yes. It was closed to the skin at 4 locations and packed in between. The rationale, skin was closed at some point. Okay, what I should have said, all right, I'm going to just say something as I'm saying that. We're going to assume in my presentations that they closed the fascia. I didn't, in every single case I'm saying, I remember say closed at all tissue levels, but anyway. So fascia was closed in that case, and the skin was closed at 4 points. Thus, and this is straight out of the definition, if any portion of incision is closed at the level of the skin by any manner, a designation of a primary closure should apply to that surgery. If you are reporting colos in your monthly reporting plan, should this case be entered into your denominator data? So start your voting, get your little clickers out. Okay, I'm going to give you 10 seconds. Very good, yes, because this was excellent, you guys are sharp. I thought I had a rationale in that case. Well, I guess I did. So the rationale on that is that, remember, in your denominator data, you are putting in open and closed procedures. So this is the next one. A patient is admitted with an acute abdomen. They're taken to the OR for an appendectomy for a suspected ruptured appendix. Wound class is 3. The surgeon does not close the incision, leaves it open with a wound vac to heal by secondary intention. Is this procedure primarily closed for 2014? Set your clickers, yes, no. All right, 10 seconds. Correct. It was left completely open with a wound vac, kind of like that picture I showed. It wouldn't have been quite that big of an incision for an appy. That'd have been a bad appy if it looked like that. This incision was left completely open. A non-primary closure is defined as closure that is other than primary and includes surgeries where the superficial layers are left completely open during the original surgery, so they can't be classified as a primary closure. So if you're following API in your monthly reporting plan, should this procedure be in your denominator data? Yes. No, it was a contaminated case. Let's see if everyone's got this. All right, 10 seconds. Oh, good. This one I was a little nervous. Yes. And this was, in some ways, it drove a little bit our decision to, like, we want to just, you tell us all your colos that are happening in your inpatient OR, because I cannot, there were a lot of times that I heard, well, we don't send NHSN our colos where it was like a contaminated. We don't send, I think we're not supposed to send NHSN our wound class 3s and 4s. And I'm like, where is that in the definition? There's no, it never said you have to have such and such wound class to be an NHSN operative procedure. It was never driven by wound class, and neither was the reporting of an SSI ever driven by, oh, don't send us your SSIs if it was a wound class 3 or 4, because that's what the SIRs are taking in. Not so much the one that goes to CMS, but ours. If you look at that for colo and hist, your wound class is definitely taken into account on both of those. So that is, I just want to clear up that it's really cleared up this year because we're saying send them all, but in the past we've really heard people were holding back. And then how can you say we have a level playing field when we're looking at our data in terms of comparative data? So good job on that. Wound class, I keep telling you my rationale before I go to it, is not a part of the NHSN operative procedure definition, and a high wound class is not an exclusion for reporting in your denominator data. All procedures that meet the NHSN definition of an operative procedure should be reported if they're part of your facility's reporting plan. So let's take the same case, so if you have to look back, and that patient was now readmitted 2 weeks later, that person who had the ruptured appendix and had the open, other than primary closure and a wound vac place. They were readmitted 2 weeks later. They were in for a week, so it's about post-op day 21. They have a fever, acute abdominal pain, and CT evidence of 2 intra-abdominal abscesses. And they do a CT-guided drainage of 100 cc's of purulent drainage. The drainage is culture positive for E. coli and B. frag, and the patient meets criteria for a GI IAB organ space SSI. Because this was a contaminated case, this infection should not be reported to NHSN as attributable to the API procedure. Is that true or false? All right. The voting is open. You guys are nice and fast. That break must have given you caffeine. I heard that you all drank 60 gallons of coffee yesterday. Had anybody told you that? You didn't hear that. I was somewhat of a contributor to that, but wow. I did the math. I'm like, is that half a gallon a person if there's 300 people here? It just shows how much coffee we have to drink to do our jobs and get through this much. All right, so. Very good. False. I sort of touched it. But this really, I think, I don't know if how many of you, I saw some head nodding. I think this has been happening in the past. People just thought, yeah, I don't have to tell them that. It was a contaminated procedure and they got an SSI, but, NHSN doesn't want to know that. And that was sort of some urban myth that occurred, we think. So as of 2014, incisional closure is no longer a part, am I beating you over the head with this? It's no longer a part of the NHSN operative procedure definition, so all otherwise eligible procedures are included, and this is the biggie, any subsequent infections that meet criteria should be reported and linked to that open procedure. Again, it won't be used in SIR analysis and show up in your analysis for a while because this is our baseline year. And then, as I think Maggie has said, we're looking at stuff that's based on 2006 through 2008 procedures. So a little bit apple and oranges at this point with the changes. But what's beautiful is once we've all stabilized and we re-baseline, it'll be I think some really good comparable data. So. This is new duration of operative procedure. You can probably guess why we had to have a new duration of an operative procedure, because what was our old duration was incision start, incision stop. Well, we've just removed incision as necessary. These procedures are not necessarily closed. So we had to have a new definition for your duration time. You don't have to put in the procedure start time in the application. You never have. You have to figure it out in your head. How many times have I counted on my fingers? 1, 10, 2. You have to figure out how many hours long the procedure was. But the procedure start time is when the procedure is begun. Now, for a patient that's going in and having an incision, it's beginning when they make the incision. They've begun that procedure. But if it's someone who arrives with an open wound and maybe it was just closed to the level of the fascia, it's when they start and cut into the fascia or start the closure of that procedure. So again, it's the procedure start time, and the procedure finish time this was all taken from the American Association of Clinical Anesthesia Clinical Directors. It's right out of their guidelines all these times, and they're ones that AORN, when we were looking at this, very much assured us so you can blame AORN, they assured us that this is a very common time that is captured in most OR records. Sometimes it might be called procedure stop time, it might be called procedure finish time. You might have a different word for it, but if you work with which you've probably already started doing that, your OR liaisons to capture the time that most closely reflects this. the most common question I've been getting is, does this match anesthesia stop time? And the answer is no, because anesthesia stop time, when we did some investigating and looked at their definition, if you have a really complicated case, some of your cardiac cases and others, they don't have an anesthesia stop time. You see them in the elevators, they're bagging the patient all the way up to the ICU. That anesthesia stop time doesn't finish until they sign off on that patient who goes from the OR to the ICU directly. You'd have these extreme extended stop times. So it isn't the same as your anesthesia stop time. Now, we did not give a workaround for height and weight. I've never seen, every hospital I've ever worked for, they wanted to know the patient's height and weight. It's also often needed to be used for dosing of patients. You have to know their BMI, you have to know their weight for dosing of different medications. The height has to be entered in feet and inches or meters. Either one that you enter, it'll transpose and fill in the other one automatically. We have a little glitch that they're fixing right now, that what we want it to do is to automatically, if you put in 68 inches, it will be happy and it will convert it to 5 feet 8 inches, for example, but sometimes that doesn't work. So if you get an error message, just try in your head to switch it. We're working on fixing it. It's been reported, but just put it in as feet and inches. And there was a little problem with meters for a bit. This was a new field, that if you put in an odd number for a meter, like 1.63, which would be the equivalent, I'm making this up because I don't know, it's a half an inch of something, like that's 5'10½". Those odd numbers, for some reason, were giving you an error report. Again, if you enter your meters and you get a little error, try bumping it up to an even number, but we're working on fixing that as we speak. So hopefully we'll stop getting these error messages with the height. The weight is the most recent weight recorded in the medical record in pounds or kilograms, and it then converts and does the other one for you, or otherwise closest to the procedure. If they didn't, the last one they got was at the pre-op check, use that. We didn't mean you had to absolutely put the patient on the scale before or after. We're not being ridiculously picky about the weight, so that's what we're saying, the most recent or closest to the procedure that you can find in the medical record. So, and I don't know if Dawn will be upset that I'm saying this, because we really, really don't think this should be happening, but there have been a couple cases where a patient arrives, has never been seen at that facility, ever, has a procedure done, and then maybe, I don't know, they sign out AMA or something, and there literally is not a height and weight on that patient. There's no other medical record to look at. They didn't capture anything in the OR, and you can't send that record over. You'll keep getting an error message because something has to be in that field. You guys have to promise me you won't abuse this, because it should be extremely rare that this would occur, because you have access to the entire medical record, and if they didn't capture it at that thing, I want you to look back when they were there before for something and try to find the height and weight. I want you to look in the OR, and I want you to look at all available records to find this, because this is an important field. This is what's going to give us, when we readjust, think about this, this is what's going to give us our obesity. Think of the risk factor for obesity with our SSIs. But it will give you an error message, and if you absolutely can't find it, you have to put in 1 pound, and if you have to put that they are 1 foot tall. And that will tell the Maggie folks that this was not available. And the problem for you all is it's not going to show up in your risk-adjusted data. So work hard with your IT departments, work hard with your nursing staff. This, we never expected we'd need any kind of workaround, and we didn't give it, to get these fields available for you all. And just let people know what good data it's going to give us in the future for risk of SSIs based on obesity. Diabetes, so this is also a new field. It isn't new, because those of you, how many of you have been reporting C-sections? Yeah, probably the Pennsylvania folks. Those Pennsylvania folks, yeah. Again, don't shoot the messenger here. Remember the HICPAC working group I was telling you about? This was the very, very last field that everyone argued over. Really, this was a toughie for the HICPAC working group. And this is the definition that they came up with, and it is based on treatment of a patient, that a patient is actually receiving treatment, not for their diabetes, not just they're controlling it by diet alone, okay? So the definition, it would exclude a person, though, who receives just, there are especially cardiac procedures, and a lot of different skip measures. You have to control their glucose right around the time of the OR. So you might see a patient who got a dose or two to control some hyper or hypoglycemia around the time of their OR procedure. We're not talking about that. These are people that are being treated with this. So we've had some issues with people saying, you know, I don't have a way to find this, and we don't, many people have found ways to find it, but at this point, we did develop a diabetes workaround for you for 2014. Again, the field is there. It had already been built in the application. If at this time you don't have an ability to capture this field, just send over all your procedures as a default to know that they're not diabetic, okay? So we did offer a workaround that's a very easy workaround. Now in yellow, you'll see what I put here at the bottom. We have gotten a lot of feedback from our users that they would like this to be based on an ICD-9 or what will be ICD-10 diagnosis code of diabetes. And I think probably, I would guess a lot of you may be doing that already, even though we didn't, because then everyone was asking me, where's my code list? Tell me my list. I said, we didn't make a list because we didn't make this code base. But we've heard your concerns, and we are actively in discussion about this, and it's the time to do it because right now, well, ICD-9s go away in October 1st, so we're going to be needing to look at what the ICD-10 codes look like. And they may be very well suited to this, but at this point, it is not a code-based system. Now, the rationale isn't, you know, I've been trying for all of these to give you the rationale behind why we asked for this, which does have an added burden. You know, I know that as years of being an IP. But obviously, the diabetes and obesity, which will be determined, and I'll show you this, what's really neat, because someone said to me, well, you know, BMI is what's important. You should be determining the BMI. Well, the person hadn't gone into the application yet because as soon as you do, you see, and it was new, they didn't know it yet. As soon as you put in the height and the weight, boom, the BMI automatically fills in. So I can pretend I'm a patient and check my BMI, you know, as I'm trying to lose weight. Oh, let me see if I've lost, is my BMI any better? I can just go into our application and figure it out myself. So anyway, so that was to capture our obesity, and it automatically calculates the BMI for you. And it will give us much better risk-adjusted data in the future. And probably, you know, again, we're rebaselining everything in 2015 when things have stabilized, and so your analysis, you know, the analysis that you do for risk factors should be available after that. Now, that's covered all the big changes. Our definition of an NHSN inpatient did not change, or an outpatient. If they are a inpatient, it means that their day of admission, their day of discharge are 2 different calendar days. If they are an outpatient, it means their day of admission and their day of discharge is the same day. And so what I will say, then that's the same day. You know, so the way I'm going to, what I do want to address for this is that I get a lot of questions, and again, it's that definition. NHSN definitions don't go by people's billing code definitions, okay? It's just a whole different definition. And CMS bases their definition of, like, you are supposed to be sending your inpatient procedures to us based on our definition. So if you have an acute care OR, it's your main OR, where you have inpatients having their hysterectomies, and you have outpatients having their hysterectomies, if it isn't happening in an outpatient surgery center, and you have hysterectomy cases that they send home the exact same day. They come in at 8, they have their hysterectomy in your OR at 10, and they're home at 7 that night. That should not go into your denominator data. It was done in your OR, but it does not meet our definition of an inpatient HIST procedure. But if they come into your inpatient acute care OR and they come in one day and spend and leave the next calendar day, that is considered an inpatient HIST procedure, whether for some billing purposes that was called a outpatient or an observation patient, you know, whatever, it still meets our definition of an inpatient. Operating room hasn't changed one bit. I'm not going to linger. This is a long presentation, but these are Most of your C-section rooms hopefully are coded as meet the standards for an operating room. Many cardiac cath labs will meet, and that's where you'll see maybe an inpatient that gets sent to cardiac cath lab to have a pacer insertion, and pacemakers are an NHSN operative procedure. A little reminder that when you do make a decision to follow a procedure category, you're following all of the NHSN procedure ICD-9 codes that fall in that category. You can't say, well, I'm just going to follow 6831s and 6839s. You need to follow that whole grouping that meets our definition based on ICD-9 CM codes of abdominal hysterectomy. So this would be shows for amps. Okay, I'm going to show you, even though I have a little what I call my errata slide at the end with our errors, and this will also be in the NHSN application. There's a reporting instruction, which we're going to get to, but I want to show it to you here. There's a reporting instruction that we now are reporting all APIs. We don't want you to look up every API and delve in and see, was it incidental, or did they just do this? Was it a rupture? It's just an added burden. If it comes across coded as an API, send it to us in your denominator data as an API if you follow those. There is a parentheses in this table 1 currently, if you look at it, that says not incidental. We didn't realize it was in there. You know, we put the reporting instruction in, but it says, and that should be, just cross that off. It should just say that it shouldn't say not incidental APIs, because we changed that in 2014. We'll get to that. That's table 1. So we're going to move on now to how to complete a denominator for procedure form. Now, for many of you, this is old hat. Your collection period is a month. You complete a denominator for procedure form for every operative procedure, meeting the NHSN operative procedure definition that was done during that period in your monthly reporting plan. And you try to get that data submitted within a month of the end of the reporting period. For example, if your monthly reporting plan indicates that you monitor colo procedures in January and 43 colos were done that month, then you should enter 43 separate colo procedures into NHSM by the end of February. You do not want to wait, you get panic calls, to the end of, or the day before, like CMS submission deadline for this, because you're going to have, a real problem on your hands if it takes a while to enter that many. And so you want to make sure you get them in a timely manner. And Maggie is going to take the last half hour, after lunch of the 2 hours we have, and she's going to be addressing, because you're going to see, when's she going to talk about how to import data for using like CSV files or CDA. So Maggie's handling that portion of it, we'll end with giving you details on importing procedures. So the first part, as it is for all of ours, is that you have your basic patient information. Anything with an asterisk is a required field: your patient ID, your gender, your date of birth. Now remember, with patient ID, you want to use the ID that lives with the patient admission to admission. Many facilities, you get the patient ID number, and then you might have a what you call an encounter number, or it really links it to that particular admission, but use the one that lives admission to admission, or you'll have problems with being able to have your information linked, because the procedure, you just have to use that permanent number as your patient ID. And then again, your NHSN procedure, your date of your procedure, and your NHSN operative procedure code. And that complete list of the NHSN operative procedure codes is, obviously found in the SSI section of the manual. And when we say with code, that means not the ICD-9 code. This is a colo, this is a HIST. That's the code number that has to go in there. The ICD-9 is, see that next to it? We don't require the ICD-9 code to be entered. Some of you may be choosing that, but it's not a required field. So if you do enter an ICD-9 CM code first, the NHSN will automatically autofill and know that that code, like for instance, is a abdominal aortic aneurysm repair, and so it autofills it for you if you're doing that. Then you get into the next section on a denominator form, which is your actual procedure details. So first of all, you know what the definition of an inpatient or outpatient is. We just did it. You'll note that on every form. That's required. So for most of you, some of you may be following some of your outpatient surgery centers. Most of the time you all will be entering that this was not an outpatient. You're going to use your new duration. This didn't change. The field is still just a duration field, but you're going to use your new procedure start time, procedure finish time definitions. Now, in Chapter 9, which is the SSI protocol, still sometimes say chapters, but it is Chapter 9 if you print it out. There are a lot of reporting instructions, and we reformatted, and I hope people found it helpful, we reformatted the SSI section, and kind of it flows, I think, a little more easily read, and we have, a whole section that is a little extra helpful. You could almost think of them as FAQs, reporting instructions for your denominator data for this, when you're entering in procedures and you have like a question, if you're not sure what you're supposed to do, look there, because a lot of times when I'm answering questions, I say to people, oh, that's in your denominator reporting instruction. Here it is, and I'll cut and paste it. That's reporting instruction number 4 or something. So get familiar with those, and every year we sometimes add a new one that we realize might be helpful, that people have been asking a lot of questions about. It's just kind of like the extra stuff around denominator reporting. And then we also have the same thing for when you're thinking about your numerator, your surgical site infection. We have a lot of details on reporting instructions for that too. So here's the only the big denominator reporting instructions was, again, the incidental APIs. We used to say we only want we don't want any incidentals. We just want your APIs that had to do with a real, maybe appendicitis case. And the burden was just, especially with so many people running off of line list of here's these operative procedures that happened, here's the APIs, for them to open up every one and determine, should it, shouldn't it just didn't really make sense. And then for XLAPs, it was the same thing. We had a reporting instruction that if a person had an XLAP that then led to any other NHSN operative procedure being done in that area, like we open it up, what's going on in there, that's what an XLAP is for, and then they did something else, you weren't supposed to necessarily tell us they had an XLAP, even though your coders may have definitely coded an XLAP. Again, it would make you have to almost look up every XLAP and see if something else happened. Now, that being said, someone did point out, and I confirmed it, there are coding rules. I am absolutely not a coding expert. And your coders, you hope, are the subject matter experts as your coders. There is, when you all go out and get your ICD-10 books, don't waste money on ICD-9 at this point, there was at least an ICD-9, a reporting instruction that said if they do an XLAP and it leads to them going in and doing surgery on the colon area, don't put an XLAP in. Well, that was a coding rule, it wasn't, NHSN rule or anything. So hopefully your coders, those aren't coming across anyway. So I just want to let you know that at this point, if you're coders and if you're basing your coding off of line lists that either come from your OR and they said they did an XLAP, or that comes from your coders, go ahead and just report it as an XLAP. Some operative procedures have more than one incision. For example, a cabbage, some CEAs, fusions, refusions, PVBY, they can have more than one incision. So an example would be a cabbage. They might have an incision on the donor vessels made for the leg, and then they also have the chest incision. And like a fusion with an anterior and a posterior report. You complete one denominator for procedure. You're not putting in 2 denominators, one for the leg part of the cabbage and one for the cabbage. That's one operative procedure, with the duration time being from the start to the procedure finish time. But if procedures in more than one NHSN operative procedure category done through the same incision, and I get asked this a lot, during the same trip to the OR, you want to then create a record for each procedure that you are monitoring in your monthly reporting plan and use the total duration for the whole thing, okay? So I'm going to give you 2 examples. You could have a person that they were planning to do a cabbage and they were planning to do a card. They knew they were going to do a cabbage and they were going to replace a valve at the same time, okay? It's going to make that a little longer procedure, yes. If you are from a hospital that's following cards and following cabbages, you are going to put down the entire time that that took on each of those. So your card is going to say that this was a 5-hour procedure, and your cabbage is going to say that this was a 5-hour procedure. All right, so you're going to have both of those. The other question that I got, I'm giving you all my little thinking of these things I get, is I've had someone the other day asked and said a person, they went in and they were planning to do a hyst, but when they got in there, they realized they had to do a colo procedure as well. You know, so it was like, surprise. So am I supposed to put that colo in because they didn't think they were going to do a colo? I'm like, yeah, you absolutely, if that colo is coded and came across, you want to put that colo in. It was a surprise, but you do put in the colo. Because the thing is, they weren't, it was something like, well, what if I wasn't following HIS in my plan, but I am following colo? It's like, yep, the colo goes in your denominator data. This is an exception here, and we have had this happen, where they send a patient down, and for some reason they don't, the coding, they were sending them down to have a CBGC. Remember, that's when just a chest, usually it's when they're doing internal mammary, so they thought the patient was just going to come out with a chest incision, and that got coded somehow, probably based on how it was entered into the OR data. During the procedure, they realized they were going to need to use a leg vein, and so they actually did a CBGB on the patient because they harvested a leg vein. So a CBGC really became, also a CBGB. And when that happens, you don't send it over, obviously, as two procedures. You just send it over as the CBGB because that tells you there's the chest and the leg incision, okay? So basically, and that happens sometimes. So this is our 24-hour rule, I sometimes call it. So if a patient goes to the OR more than once during the same admission and another procedure of the same or different NHSN operative procedure category is performed through the same incision within 24 hours of the end of the original procedure, you only report one denominator for procedure form for the original procedure. Okay, so we have an example for you here, and then you're going to combine add the time from the second onto the first. So a patient has a colo, and it was performed on Tuesday morning, and it had duration of 3 hours and 10 minutes. Tuesday evening, the patient returns to the OR where the colo incision was open to repair a bleeding vessel. That's an OTH other, I just happen to know that. The duration of the second procedure was 1 hour and 10 minutes. You only report the colo with a combined time now of 4 hours and 20 minutes. That OTH other procedure is not going to be in your denominator data. And the concept here is that that second procedure is really only being done because that original procedure usually has some sort of complication that needed immediate attention. And so it's almost treated as an extension of the original one where they're so close together in time like that. If that same thing happened and it's beyond 24-hour period, you're going to still have a colo procedure in your denominator data. And if you follow the OTH category, you'd have an OTH in your denominator data that represented that repair of a bleeding vessel. Now this, we're going to clean up the language around this because I haven't had a lot, but a couple questions. If you look in the SSI protocol, under our definition of a primary and non-primary closure, there is this little note here. Oh, where'd my mouse go? Come on, mouse, where'd it go? Anyway, and it, this note reflects what to do when you, this note completely reflects how you're supposed to assign the incisional closure when someone goes right back to the OR within 24 hours. Like if they went to the OR and they left the incision open due to swelling, and then they return to the OR 18 hours later to close that incision. So that second procedure is not even going to be in your denominator data. We want you assigning the incisional closure type for the one that is in your denominator data, that first procedure, okay? So that's what this instruction was applying to. Okay? Let's try a case now and see if we can apply something. So a patient has a colo and a hyst through a single incision during a single trip to the OR, and both of these procedures are in your monthly reporting plan, which would be true for a lot of us here who do colo and hyst. The incision starts at 8:23, and the procedure finish time is 11:33. They did note in the OR record that the HIST part of the procedure, because you'll see that of when they transferred the team and you now have a different team doing the HIST part of it. You may have a different team depending on the expertise, began at 10. Which statement is true? Only the colo should be reported because it's really higher on our priority list of risk of infection, which we're going to be getting to, but some of you are very familiar with that list. Which one has the highest risk of developing an SSI? Colo is higher than HIST. Number two separate procedures should be reported, a colo with a duration time of 1 hour and 37 minutes and a HIST with a duration time of 1 hour and 33, or two separate procedures should be reported, one for colo and one for HIST, but each should have a duration time of 3 hours and 10 minutes. Which do you think is true? 1, 2, or 3? Votes are coming in. All right, 10 more seconds. Very good. It's 2. Remember, you don't split the time when you have 2 procedures like that doing between this. Number 3 is a correct answer. It's going to be 2 separate procedures, but each will have the entire duration. We'll be getting to a couple examples of when do you ever split the duration of an operative procedure. We'll be getting to that. And I'm not going to... That's just basically this is your actual, I cut this from our denominator for reporting instructions. This is in there as a very specific example telling you what to do. Because of bleeding during surgery, a drain was placed in that abdominal incision, and the incision was then loosely closed. Does this incision meet criteria for a primary closure in 2014? 1 yes or 2 no. Just to give you a little more information about that incision where they did 2 things. They had to leave in a drain and loosely close it. All right. 10 seconds. People are voting very fast. I make this too easy. All righty. Yes, that is a primary closed wound. Because they closed at any tissue level, and wicks, drains coming out are allowed. You can have wicks and drains and some packing as long as it's closed at some level at the skin. Now we're going to get into a little bit about bilateral procedure. So procedures that are performed bilaterally, we're not talking about 2 procedures in one incision, but where you have kind of a left and a right side. For example, your K-pros is a perfect example of that. Some hips I'm even seeing being done at the same time as bilaterals. In those cases, you actually do 2 separate denominator for procedure forms are completed for a bilateral hip. So to document the duration of the procedure, you're going to indicate the procedure start time to the procedure finish time for each distinct procedure separately if they told you that, or alternately take the total time and divide it. Now some people, they really very clearly note in the op note that we finished this and now we're moving on to the next knee, and then you could really know in case one knee was more complicated. But a lot of times what you really have, and in terms of burden as well, you have one time, like we did a bilateral knees and it took us 4 hours. So then you're going to just split it in half and give each knee a 2-hour procedure. So let's do a case here. So case 4, a patient has a bilateral knee prosthesis, a K-Pro, implanted during a single trip to the OR. The left K-Pro procedure start time was at 8:30 a.m. and there was no note of procedure finish time for this knee. Then they did a right K-Pro and the procedure finish time for that was at 11:30 a.m. Which statement is correct? 1 K-Pro procedure should be reported with a combined duration of 3 hours. 2 separate K-Pro procedures should be reported, each with a duration of 1 hour and 30 minutes, or 2 separate K-Pros should be entered and each should have a duration of 3 hours and 0 minutes. Which one is true, is correct? And you guys are voting really fast. You're ready to go to lunch, aren't you? Watching that clock there. All right, 10 seconds, because you've got somebody. And that is correct. This was a bilateral. Number 2, you're going to take that and split the time since they didn't note it. Bilateral procedures, you split the time if they didn't note it between the two. Another common one, if you think about that, if they do bilateral breast procedures is the other one that jumps to mind. The hips, knees, and breasts are the most common where you would apply this. So I want to let you know that there's new and updated reporting instructions for use, again, in page 915 is where you're going to find your actual SSI. 9 means it's chapter 9. 9-15 is where you'll find your actual event reporting instructions for when if you have a question about how to report infections, there's additional reporting instructions, and your denominator reporting instructions start on page 19 of your SSI protocol. Now let's go next to your denominator for reporting, so we can get through denominator before the lunch break. This is just, again, your wound class is going to go in next. It's a required field. We removed unknown as a choice, so if it comes across as unknown, you're going to want to talk to the team, educate them, hopefully get them to enter one, because if it's going to come across as an incomplete record, so you're going to have to get that data and educate your, it should be extremely rare. Wound class is a very important part of an operative procedure. And we get a lot of questions about wound class. Can you please tell me what this wound class should be? Tell me if I should call this the IPs. And what should I call this wound class? What should I call that? We have really stopped giving wound class recommendations. That's not our role in NHSN. It should be applied by someone who is in the field and involved in that specific case. So we're going to talk, a little bit more about this, but you'll note here at the bottom of this one, clean wound class, there are a set of procedures, and they're right there, Appies, Billies, procedures, cholecystectomy, colos, rectal, small bowel, and vaginal hyst. You will never be able to enter those when you're entering your denominator as a clean procedure. That's really the only time at this point that we really want an IP. We'll have to maybe put in something different if you're still having problems with your OR calling any of these clean procedures. You're not going to be able to, because clean is not an option on your drop-down menu in the application. It just starts as a clean contaminated. So that's where you'll work again with your OR liaisons, your OR education team to make sure that they know this group, based on really outside expertise and experts in this, said these should never ever be called clean. Aside from that, we really have removed any the sense of saying that we're going to tell you this has to be clean, contaminated, or whatever. So that's why we don't like to assign wound classes. In last year, under wound class, we had an asterisk next to the word genital. And that asterisk had said that actually, the word genital should also, this was last year, should, and you'll see if you look back, what also means the male and female reproductive tracts, which are quite different than your genital tract. And that was something NHSN had put in. That was our own thing we put in last year, and we realized we aren't happy with it. We took it out. It isn't part, we really have the wound class exactly how it's written now by the group that developed these. We didn't develop wound classes. So we removed that because that would imply that an ovary is, always a contaminated case, and that's just not true. Or procedure on the testes is contaminated. Well, that is not true, and we got a lot of pushback about that. And then you've got your contaminated, dirty, infected. These did not change. They're cut exactly from the guidelines. I went over this, but these are the procedures that can never be coded as a clean wound class. So based on this, you really could have a clean C-section. It's not your genital tract. It connects to, but we got a lot of questions like, we have a lot of really planned, elective, non-ruptured C-section patients. I mean, they're kind of clean as a whistle when they go in. Do I have to call that clean contaminated? And we have there has been historically that's been said yes, but we now have saying, you can have C-sections that are elective plan, no rupture, no connection to the genital tract there, that could meet criteria. So again, what we're really putting it to is it really needs to be based on the findings of that particular case. We're not involved there. We don't know what happened in that OR, and let them assign the wound class. And if you feel like there's some really gross errors going on, then you need to work with your liaisons in your OR to correct those. General anesthesia hasn't changed at all, our definition there. I'm going to breeze by the things that have been the same for years for timing, but it's all here if you need it. ASA score, again, I think a while ago, but we took it out, there was an unknown. We have no more unknown. You're going to need to know the ASA score, and this is set by the American Society of Anesthesiologists classifications, and we updated ours a little. There'd been one update, so I mean, it's very subtle, but the ASA scores that are written in the manual are up to date. This was the new wording. It was a little different, tweaked, nothing substantive. But there is an ASA score of 6 that you guys might find in your records. How many of you have ever seen a 6 come across? Oh, I've got about 10 hands up. What 6 is the ASA score that's usually assigned on a brain-dead patient when they're harvesting organs. And so we do not want those. You don't want to. Those procedures are not going to go into your denominator data. A procedure done on a brain dead ASA 6 patient shouldn't go in your denominator data, because if you think of it, there's absolutely zero risk that patient's going to get an SSI. So, I mean, that bluntly put, that's true. So. Okay, emergency procedure. Select if the emergency, and these again, a lot of these things you're seeing pasted here from the table of instructions. So if you forget this, look at your table of instructions for your denominator procedure. So an emergency means that they really did not allow for your standard, immediate pre-op preparation that you do on those cases. What's your normal pre-op prep that should be done for a patient with that procedure that's being done? They couldn't get their vital signs stable, they couldn't do the correct antiseptic skin prep, or for colon procedures, they were not able to even do a colon prep. That's an emergency procedure. If they were there long enough that they got everything done perfectly, well, that probably won't get coded as an emergency procedure, because you know how long a bowel prep takes. That takes a while. So now trauma, it seems like it shouldn't be a difficult field to fill out, but I do get questions about this. Trauma, yes, no. They said, well, like what kind of trauma? How long ago? And like someone had trauma in their knee a year ago and now they're back and we're fixing that trauma, we're tweaking it a bit. I'm like, no. We mean the patient who is on the table right then has sustained a trauma that you are in an immediate nature needing to repair. So a patient who has a fall and breaks her hip, blunt trauma, that's blunt, I get that one a lot, has a broken hip, now needs an H-Pro procedure to be done. That is considered that was due to a trauma. Now, they might not have gotten that patient to the OR the day the trauma happened, but that is being done due to a fractured hip that occurred. But, not one that occurred a year ago and now has to have a revision. So hopefully that'll help with that. Scope. This is if the entire NHSN procedure was performed using a laparoscopic or robotic assist. And so that's when you'd say scope yes as one of the risk factors. No if it was extended for hands assist. There are some huge extensions they do now, and they take a lap site and they open it up like to 3 inches long and put in these wound protectors and hand assist. So you have the surgeon actually putting their hand completely into the colon and pulling things out. Well, now that would be a scope no, because you have like a 3-inch, you actually have an incision. It's not no longer just a laparoscopic procedure. If a scope was used for an entire hyst or vag hyst, but they then just remove the uterus through the vagina, that's still a scope procedure. The fact that they had to actually remove it does not make it not a scope procedure. The diabetes field, we went over that definition, and you were given the workaround for that. So that's the diabetes. It's not new. It's just that before it was only there for C-section patients, and now it's for all procedures that are in your denominator reporting plan. Height, weight, we covered. Just to remind you, these are all these new wonderful risk factors we'll be able to have risk adjustment for very soon. And this is a picture of what it looks like, where if you haven't actually visually seen it yet, you can see how the height is in, it automatically figured out the meters. The weight is in, it automatically fills in kilograms or pounds, depending on what you put in, and there's that wonderful little BMI that it calculates for you. Closure technique, I'd already shown you a picture of that. It's going to either say primary or other than primary on your drop-down, and if you tend to fill out a form and then hand it off for someone, this is what it's going to look like. We already discussed that definition. Surgeon code, this is not a mandatory field. It's certainly helpful, and I highly recommend it so you can give surgeon-specific information back. So that's where you can use that. Still not asterisk, not required. But a question I get a lot, particularly for reconstructive cases or breast procedures, if you follow those, they'll have a team, a primary physician who does the bilateral mastectomies, and then a plastic surgeon who comes in and does the implants. So you have a team. And they said, who should we attribute this SSI to? Well, this is not a required field of ours, and we don't really dictate how you want to do that, but we say it's usually the person who's primary in the case, who has the longest part or more complex part of the procedure. But if you have a team that works a lot together, you can just set up a surgeon code team. So your code that says 300, well, that's Dr. X and Dr. Y who always do these two cases together, and then you're not pointing your finger at any particular surgeon. Now I'm going to stop. This is a perfect place to stop.